So athero from the lipids. Here you have a cholesterol plaque in the intima, cholesterol deposition in the intima, and sclerosis from hardening. So due to this cholesterol plaque deposition in the intima, you will have a hardening or stiffness in this wall, which also means sclerosis. So atherosclerosis is very common disease of elastic arteries and large. It affects the large and medium sized muscular arteries. So it is important to know that atherosclerosis affects the medium and the large arteries of the body. Now, it is a form of arteriosclerosis, as what just we say, arteriosclerosis, which is a hardening, stiffness in the walls due to proteins, anything. Okay, as we say yesterday, it could be caused by proteins, like what happened in hyaline arteriosclerosis, or any other causes. Now, where does this atherosclerosis happen? Most commonly, it happens in the abdominal aorta. So the most common site for atherosclerosis is the abdominal aorta. After that, you'll have coronary artery. After the coronary artery, which is the blood vessels of the heart, after that, you'll have a popliteal artery. After the popliteal artery, you'll have a carotid artery. And after that, you'll have a circle of Wills. Now, the most common site is abdominal aorta. The most common site of atherosclerosis, abdominal aorta. After that, it will have coronary arteries. Now, what are the risk factors for you to have atherosclerosis? As we know, there is a modifiable risk factors and non-modifiable risk factors. The modifiable risk factors is the risk factors that we can change it. The non-modifiable, we can't change it. So the modifiable, we can change it to reduce the risk and to treat this patient. Now, the modifiables like hypertension, for blood pressure is high, you can give medications to decrease his blood pressure, so you can eliminate that risk, for example. Also, if you have tobacco, smoking, cessation of smoking is important. You should tell the patient you need to stop smoking to decrease the risk of having heart diseases, coronary artery disease due to atherosclerosis. Now, other modifiable risk factors like the dyslipidemia, and you know the dyslipidemia is that there's disruption in the lipids, in the blood vessels. So you have decrease in the HDL, which is important and indicate that this patient is healthy. If you have decrease in the HDL, you could have, it indicate that there is a problem in the lipids. Now, if you have more LDL, you have high LDL, this is indicate that you have dyslipidemia. And of course, if you have high cholesterol and all of that. The non-modifiable risk factors like the age, you can't change this one. So if the patient have, the age is important risk factor to have atherosclerosis, which is the lipid deposition in the arterial walls. Also, the males have a more risk to have atherosclerosis, lipid deposition in the walls than the women. Now, also postmenopausal women. Postmenopausal is a risk factor. Now, why? Because you have estrogen in the premenopausal woman. Now, you have estrogen in the premenopausal woman, and this estrogen helps to regulate the metabolism of lipids in the liver. So this estrogen helps to regulate the metabolism of lipids in the liver, and this estrogen is found premenopausal. Thus, the absence of this regulation of the lipids after menopause, because of the absence of or decrease in the estrogen, this will lead to high risk for the postmenopausal woman to have atherosclerosis. So the estrogen helps regulate the metabolism of lipids in the liver. The drop in estrogen levels during menopause lead to higher LDL and cholesterol and triglyceride levels. Now, as you can see here, the dyslipidemia, you have cholesterol depending on the cholesterol in the blood vessel, depending on the LDL, the HDL, and triglyceride. The more you have HDL, it is better for your health. So decrease in the HDL, like if you see the ideal HDL, as you can see here, the ideal HDL, normally this HDL need to be more than 60. Okay, if you have less than 40, for example, it is abnormal, it is low to have it. Now, the cholesterol should be less than 200. Less than 100. Okay, now if you have the LDL should be less than 100, the cholesterol should be less than 200, and so on. If you have this normal ranges disrupted, the LDL get higher. It is like more than 200, more than 100, and the LDL more than 100, and so on. Here you can diagnose dyslipidemia. And also if you have triglyceride, the ideal it should be less than 150. If you have triglyceride more than 150, this is abnormal and you can diagnose dyslipidemia. Now, as we say, the other non-modifiable risk factors for having atherosclerosis is the family history, of course. If one of the family members have atherosclerosis, this will increase the risk to have for the other family members to have atherosclerosis. Now, what are the symptoms for atherosclerosis? As we say, this atherosclerosis can affect the abdomen and can affect the coronary artery disease, the coronary arteries. If you have atherosclerosis in the coronary arteries, this will lead to angina. And also, you will have ischemia in the organs of the body, depending on which artery is affected by this atherosclerosis. So you could have angina, you could have claudication if it affects the popliteal artery. As we say, one of the arteries that affected by atherosclerosis is the popliteal artery, and if this popliteal artery is affected, it will affect the lower limbs and cause claudication. Now also, atherosclerosis could be asymptomatic, have no symptoms. Now, progression, how this happened, atherosclerosis? First of all, you need to have endothelium injury. So endothelial cell dysfunction, and this will lead to macrophage and LDL to accumulate. Now look here at the picture, down here at the picture. The first thing, this is here the normal artery. You have here the lumen, here you have the smooth muscles and so on. Here you have the endothelium. Now the first thing to have this atherosclerosis is that you will have endothelial injury, damaged endothelium, and after that you will have a macrophages come in response to this damage in the endothelium. You will have a macrophages, as you can see here, and after this macrophages come, you will have some type of the liver of the macrophages we call the foam cells. Now this foam cell is a type of macrophage. Okay, so this foam cell is a type of macrophage that comes in response to endothelial damage. Now what will happen next? As you can see here, there is the inflammation is important in pathogenesis of endothelial cell dysfunction, and this will lead to macrophage and LDL accumulation. Now after this foam cell, which is a type of macrophage, you will have also LDL, and LDL is type of lipids. So you have this LDL, which is a lipid, and you have this macrophages, which is the foam cell, combined together and form, as you can see here, the fatty streaks. Here you have the foam cells, and here you have the macrophages and the LDL. So they join together, combine together, And this is how we call it, that's why we call it atherosclerosis, which is a deposition of lipids. Because as you know here, you have LDL deposition and combined with foam cells to form a fatty streaks. After that, you will have immigration of the smooth muscle cells. After that, you will have smooth muscle cell migration into the lumen. So you will have here fats, LDL, macrophages, and smooth muscles, and all of that will cause inflammation, of course. And this also block the lumen. It's make the lumen narrow, so you will have ischemia and any diseases due to that cause, which is like the angina, claudication, which decrease the blood flow to the tissues, the organs. Now, as we say, the macrophages in LDL accumulate in the lumen, and after that you have the foam cell formation. This will lead to fatty streaks, and then you will have smooth muscle cell migration, which involve these two. Now, to also involve the growth factors, as you can see here, these smooth muscle cell migration also continue growth factors that lead to more proliferation of these smooth muscles. So you'll have growth factors will lead to more proliferation and extracellular matrix deposition. You'll have more connective tissue and so on. So this will lead eventually to fibrous plaque and complex atheroma. You'll have atheroma, which is a clot. Now, also you could have calcifications. Now let us look for this here. This picture, here you have the atheroma. This is the atheroma, this is the artery. Here you have narrowed lumen. This is the lumen become narrow. This will interrupt the normal blood flow to the tissues and organs. And this is how it will cause symptoms. Now, also, what is the complications that could be caused by this one? Now, what are the complications that could be caused by atherosclerosis? Of course, if it affects the artery and cause dilatation of the artery, it will cause aneurysm. And if it causes less blood flow to the tissues, it will cause ischemia and also infarction. Also, it will cause a peripheral vascular disease, which affect the lower limb. For example, you will have a claudication, paleness, you'll have pale, paresthesia, and so on. And numbness, all of that should be caused by the peripheral vascular disease that's caused by the atherosclerosis. Also, you could have embolus and thrombus as well. Now, as you can see here, the artery anatomy, you have this artery, the wall is composed of the tunica intima, the innermost layer, and you have the middle layer we call the tunica media, and the outer layer we call tunica adventitia. And we talk about this one. Here you have the foam cells, and the foam cells are type of macrophage that localize to fatty deposits on the blood vessel wall, where they ingest low density lipoprotein. We talk about it. Lipids is the fat, yes? So this foam cell is a macrophage that bind to the LDL. Okay, as what just we say. So where they ingest, these foam cells ingest the LDL, which is the low density lipoprotein, and become laden with lipids, giving them a foamy appearance. That's how you see it here, as we see it in the picture. This will give them a foamy appearance as a foam. And here you have the smooth muscle cells. Migration involves these growth factors, as we say, the growth factors such as the fibroblast growth factor, this one here, fibroblast growth factor, and the platelet-derived growth factor, this one here, platelet-derived growth factor, promote the proliferation and the migration in a variety of cell types. As we say, these two, they are the cause of the migration and the proliferation of the smooth muscle cells to the innermost or the endothelium, the lumen of the blood vessel. Now, aortic aneurysm is localized pathology dilatation. We say that aortic aneurysm means that, yes, aortic aneurysm means dilatation of this aorta. So aortic aneurysm means dilatation. So it is localized pathologic dilatation of the aorta may cause abdominal or back pain. One of the signs, the important signs to suppose that this patient or to further investigate for aortic aneurysm is that if he has abdominal pain or back pain. So if you have abdominal pain and back pain, you need to think of aortic aneurysm if it is severe and so on, which is a sign of leaking or dissection or imminent rupture. This dilated aorta, the back pain, the pain in the back or abdominal pain, this could lead us that this dilated aorta could rupture. It will rupture soon, or aortic dissection happens. Now, what is dissection? Dissection is a tear occurs in the inner layer of the aorta. There is a tear in the endothelium of the aorta, as we say in the intima, and this will cause a blood rush through the tear, causing the inner and the middle layer of the aorta to split. As you can see here what happens in the dissection, that you have a tear here, you will have a tear in the intima, and this intima, after that, this intima, after this, what will happen here is that this intima will have a tear, and this tear, due to the dilatation, don't forget that we are talking about the aortic aneurysm. So aortic aneurysm, there's a dilatation in this aorta. This will make the wall weak, and so the tears could happen. If the tear happen in this dilated wall, what will happen next? The blood will flow from the endothelium, from the lumen, to the layer between the media and the intima. The blood will communicate between this. Okay? So the blood will flow through between these layers. And this is what we call it dissection. Dissection means split. Okay, so the intima and the media split due to the blood between these two. Now what we say is that the pain, don't forget that the pain will cause an imminent rupture, dissection, or a leaking. There is a leaking out of this blood vessel, out of this dilated blood vessel, because we are talking about aortic aneurysm. Now, abdominal aortic aneurysm find usually associated with atherosclerosis. We know that an important risk factor actually for causing abdominal aortic aneurysm is atherosclerosis that we just talked about it, which is the deposition of the lipids in the walls of the aorta. Now, as we say, one of the most important risk factors is atherosclerosis. So it's usually, a lot of time you will find that abdominal aortic aneurysm associated with atherosclerosis. The patient who have abdominal aortic aneurysm, also he could have atherosclerosis. Risk factors for abdominal aortic aneurysm, we are talking about the abdominal aorta, don't forget that. We are talking about the abdominal aortic aneurysm, because there is another type, which is thoracic aortic aneurysm. Now, the abdominal aortic aneurysm risk factors is like, of course, smoking. If you have tobacco use, which is smoking, and also increasing the age, this will lead to weaken blood vessel walls, and weakened blood vessels wall will lead to more dilatation and aneurysm. Of course, this will increase the risk of dilatation and aneurysm. And also you'll have a male, because we say, obviously, the male sex, if this is male, if we have a male, we have a more risk to have atherosclerosis and to have abdominal aortic aneurysm as a consequence. So also, if there is family history, now may present as palpable pulsatile abdominal mass. So of course you can understand this point. You have a dilated aorta. So of course you can, by palpating the abdomen, because we are talking about the abdominal aorta, if you palpate, you do palpation to the abdomen, you can feel this pulse, which is occurred due to the blood flow through this dilated aorta or artery. Okay? Due to this artery, which is dilated, you have obvious pulse. The pulse become more clear, so you can palpate it on the abdomen. So one of the diagnoses on the physical examination you need to do is to do abdominal palpation. And this will be like there's palpable pulsatile abdominal mass due to this dilatation. It will occur as a mass. It will appear as a mass on the abdomen. So you'll have a palpable pulsatile abdominal mass, and as you know here. Now, in this picture, as you can see, this is the aorta, and here you have a dilatation. Okay, you have here a dilatation. Now, if you notice that in this picture you have a calcification, and this is obvious because you have ossification in this picture. So you have ossification, which is the white color, as you can see here. You have a white color in the artery, in the wall of the artery, which is due to the calcifications that happens to this dilated abdominal aorta or abdominal artery. Now, as you can see here, as we see this dilated aorta, you can see the dilated aorta. And as we say, there's a dilated calcified aortic wall with a partial crescent-shaped non-ossification. This non-ossification, you have here calcifications appear white, as you can see here in the picture. This calcification, you have a white region, this white, and the wall of the aorta is caused by the calcifications, the deposition of the calcium. Now there is some area here which have no ossification and non-ossification, don't have this white color. This is due to flap or a clot. This is that this clot caused this non-ossification in that aorta. So as we just say, with a partial crescent-shaped non-ossification of the aorta due to a flap or a clot, most often the most common site for abdominal aortic aneurysm is the infrarenal artery. Okay, so we have infrarenal region, So infrarenal region of the abdominal aorta. So this is the most common site to have aneurysm. So the most common site of the aorta that dilated is below the kidney or infrarenal area. So as we say, most often infrarenal distal to the origin of the renal artery, of the renal arteries. So distal to the origins, when this aorta, abdominal aorta, gives its branches to the kidney, infrarenal means below this origin. When this aorta gives its the artery's origin of the kidney. Okay, let us say it again. Now it is distal to the origin of the renal arteries. This aorta gives its branches to the kidney. Below this, after this aorta gives the branches to the kidney, you will have, this is the most common site to have dilatation, infrarenal. Now let us talk about the thoracic aortic aneurysm. Now thoracic aortic aneurysm, you can understand that thoracic means in the chest, yes? So you have As you can see here, you have the aorta, ascending aorta, the aortic arch, and then you have descending aorta, and of course, after this this also descending aorta, we call it the thoracic aorta. If this part of the aorta have a dilatation, this could lead to thoracic aortic aneurysm. Now, this thoracic aortic aneurysm is associated with cystic medial degeneration. What is this? Now, cystic medial degeneration is actually an inherited disease. As you can see here, thoracic aortic aneurysm, we can see it in the patient who have a cystic medial degeneration. And cystic medial degeneration is an autosomal dominant disorder of large arteries. Because obviously we are talking about the thoracic artery, which is a large artery. So cystic medial necrosis or degeneration, which is the same, is an autosomal dominant disorder of the large arteries, and there is a degenerative breakdown of the collagen, elastin, smooth muscles caused by aging, which contribute to the weakening of the wall. So of course, you can understand that if you have some people have cystic medial necrosis, there's a breakdown of the collagen, less collagen. Okay, there's a damage that happens to the collagen, to the elastic fibers, and all of that. And this, of course, and the smooth muscles as well. So this will make the wall of the thoracic, or this artery that it is affected, whether it is the thoracic or other artery, the artery that's affected by this inherited disorder, which is the cystic medial necrosis, it will have a weak wall. The collagen is disrupted and all of that, so you'll have a weak wall, and this weak wall of the blood vessel will lead to dilatation. So it is more often you will have aneurysm in this affected artery. So thoracic aortic aneurysm is associated with the cystic medial degeneration, and the risk factors to have thoracic aortic aneurysm as hypertension. If you have hypertension, high risk to have aneurysm, of course, and also bicuspid aorta. Bicuspid aorta, as you know, we talked about it in the previous lectures. You have two leaflets of the bicuspid aorta. Of the valve, you have only two leaflets. Instead of the normally, you need to have three leaflets of the valve. It should be normally the aorta is tricuspid, but if you have a bicuspid aortic valve, this will increase the risk to have thoracic aortic aneurysm. Also, if you have connective tissue disease like Marfan syndrome, Ehlers-Danlos syndrome, as we talked about it previously, because obviously if you have a connective tissue disease, this will make the wall weak. If you have the blood vessel wall weak, you can predict what will happen, which is aneurysm, dissection, and all of that stuff. Now also, it's associated with the third or tertiary syphilis. So tertiary syphilis can also lead to thoracic aortic aneurysm. So cystic medial degeneration and bicuspid aortic valve, and also tertiary syphilis. Now, what is tertiary syphilis? Tertiary syphilis is, you know, the syphilis, which is bacteria and so on. So tertiary syphilis is very serious and would occur in 10 to 30 years after your infection with syphilis begin. In tertiary syphilis, the disease damages your internal organs. You have damage to the internal organs of the body, and one of them, and also this will affect the blood vessels and cause thoracic aortic aneurysm. So also thoracic aortic aneurysm could be caused by the tertiary syphilis. You will have obliterative endarteritis, okay? Endarteritis of the vasa vasorum. Aortic root dilatation may lead to aortic valve regurgitation. You know that. If you have dilated blood vessel, the dilated aorta will lead to this aortic valve will not close properly. So you will have regurgitation to the heart. The blood will going back again to the heart. So So we have aortic valve regurgitation. And of course, associated with the bicuspid aortic valve, you have a bicuspid aortic valve. As we say, you have two leaflets of the aortic valve. Of course, this will lead to increased risk for having regurgitation, aortic valve regurgitation. And of course, thoracic aortic aneurysm is a risk factor for having aortic valve regurgitation. Now, this is here the syphilis, stages of syphilis. You have a primary, secondary, latent, and tertiary. We say that the syphilis happens after 10 to 30 years of the primary infection. And of course, it could lead to, as we say, thoracic aneurysm. It's one of the complications. Now here you have a traumatic aortic rupture. What will happen if there is a trauma for someone and this trauma affects the aorta? And this aorta could rupture. Now, due to the trauma or deceleration injury, most commonly at aortic isthmus, proximal descending aorta. As we say, at the aortic isthmus is the most common site for having rupture in the traumatic patients. Just distal to the origin of the left subclavian artery, and we will talk about this in the next lectures actually. Today we finish our lecture. Thank you. See you next time.